You are presented with a blank slate, an unlabeled, full-body nuclear medicine scan. The strict objective in this clinical scenario is to systematically deduce the exact radiopharmaceutical used, relying entirely on biodistribution patterns. Trying to memorize the macroscopic shape of these scans is a failing strategy. There is simply too much visual overlap between different radioactive isotopes to rely on pattern recognition alone. To solve the scan, you have to drop down to the cellular level. Every radiotracer is a biological mimic that exploits specific, predictable cellular transport systems. These organ patterns represent the cumulative activity of millions of individual cellular transporters. This diagnostic algorithm begins by looking at this flowchart. The first diagnostic fork demands a binary answer. Are the bones visible or not? Intense, clearly delineated skeletal uptake points definitively down the pathway to a technetium-99m MDP scan. To understand why the skeleton isolates this tracer, we look at the micromechanism known as chemisorption. A phosphate analog bypasses typical cellular entry entirely. Instead, it physically fuses directly into the hydroxyapatite matrix on the exterior surface of the bone. This binding concentrates the tracer specifically in regions of active osteoblastic remodeling. A bone scan tracks the rate of mineral turnover, providing a functional map rather than a simple anatomical image. If the skeleton is dark, the algorithm drops down the no bones pathway and shifts to the head and neck. We look for the presence or absence of the lacrimal and salivary glands. Distinct uptake in these upper glands is the primary indicator for gallium-67. Gallium operates in the body as an iron analog. Because it mimics iron, it binds directly to transferrin phenylketonuria receptors, which are highly concentrated in these specific glands. Free technetium will also highlight the lacrimal glands, but it presents a distinct, messy background signature that immediately rules it out. Identifying a hot face on a scan means we are successfully tracking the body's acute phase inflammatory response via iron sequestration. Variable cardiac uptake on the no bones branch isolates the MIBG pathway. MIBG is a norepinephrine analog. It enters the cell via active transport and is packaged into internal storage vesicles. The absolute rule for MIBG is that it does not naturally accumulate in the kidneys. This mechanical blind spot is what makes MIBG viable for detecting neuroblastomas. A localized hot mass sitting next to a cold kidney is clearly distinguishable, but we must also account for the physical properties of the specific isotope attached to the MIBG, either iodine-123 or iodine-131. Iodine-123 emits a 159 kiloelectron-volt photon. This yields a higher count, cleaner cardiac image, and normal faint adrenal uptake. Iodine-131 requires delayed imaging times. It is heavily utilized to estimate target-to-background noise when planning targeted MIBG therapy. Identifying a tracer requires evaluating both its biological destination and the specific physical energy of the isotope. Focusing on the abdomen requires assessing the ratio of uptake between the liver and the spleen. For white blood cell analogs, the spleen will always appear hotter than the liver. At the cellular level, indium oxine is lipophilic. This allows it to passively cross the neutrophil membrane before it is permanently trapped inside via phagocytosis. To differentiate an indium WBC scan from a technetium WBC scan, we rely on temporal kinetics. At the 4-hour imaging mark, a WBC scan will show active uptake in the lungs. By the 24-hour mark, the lungs clear up, and distinct bowel uptake begins to appear. Differentiating these tracers relies entirely on tracking the chronological life cycle and clearance of neutrophils over time. This split-screen schematic isolates 3 specific diagnostic scans that bypass complex anatomy entirely, relying on 3 pure cellular transport profiles. Fluorine-18 FDG is a glucose analog. It enters the cell through facilitated diffusion and is permanently trapped via phosphorylation. Thallium-201 functions strictly as a potassium analog. It depends entirely on the sodium-potassium ATP pump for active transport. Technetium-sestamibi operates as a lipophilic cation. It passively diffuses into the cell and latches directly onto negatively charged mitochondrial membranes. These distinct diagnostic scans are macroscopic portraits of basic basal metabolic pumps. We return to the featureless scan from the beginning of the evaluation. Applying the logic tree, we verify the absence of bone uptake and the absence of lacrimal gland activity. A hot spleen, clearing lungs, and active bowel uptake isolate this specific agent within the diagnostic tree. The spatial and temporal data confirm this is a 24-hour white blood cell scan. Board-level nuclear medicine is the observation of localized cellular biochemistry scaled up to a macroscopic level. By mastering each of these localized cellular mechanisms, the macroscopic patterns on the scan become entirely predictable and identifiable.